So this is Endocrine System Disorders Part 2. We're going to begin with the parathyroidism, hyperparathyroidism. And your parathyroids, their function is to secrete calcium. So for your parathyroid disorders, you're going to see either too much or too little. So with hyperparathyroidism, you're going to have too much PTH, too much parathyroid hormone. So you're going to see hypercalcemia. So the calcium leaves the bone and it accumulates in the bloodstream. You're going to see pathologic fractures and kidney stones because there's too much of it. It's too much calcium. And your calcium's leaving the bone, so your patient's going to be weak. So your assessment, you're going to assess the muscle weakness, renal colic, and dull back pain. The level of consciousness may decrease to the level of stupor or coma. So for the diagnostics, they're going to run the PTH levels, serum calcium, bone density, MRI, and 24-hour urine. They may do a surgical removal of the existing tumor, and the patient will be on calcium replacement for life. Your nursing intervention, so furosemide to help eliminate the excess calcium. So you're going to monitor I&O. Daily serum calcium levels may be ordered. An acid high in calcium should not be used. And if tetany occurs, you're going to give calcium gluconate. And you're going to teach principles of good body mechanics since they're going to be weak. With proper medical or surgical treatment, the patient can maintain an average life expectancy. So this is hyperparathyroidism. Again, too much calcium. Hypercalcemia. So the opposite of that is hypoparathyroidism. So this is not enough PTH, resulting in decreased levels of serum calcium. So you're going to have severe hypocalcemia, which may result in laryngeal spasm, stridor, cyanosis, and increased possibility of asphyxia. Your assessment, dysphagia, numbness or tingling of the lips, fingertips, and feet, abdominal or flank pain if renal calculus attempts to pass. They're going to have a positive Chavostic sign or Trousseau sign, and the cardiac output may decrease. For the medical management, so they're going to run the serum calcium, PTH, and serum phosphorus diagnostics. You can give calcium gluconate or calcium chloride IV. You want to remember that if given too rapidly, IV calcium can precipitate hypotension, serious cardiac arrhythmias, or cardiac arrest. So those nurses are going to make sure that they infuse that very slowly. Your nursing interventions, vitamin D supplements are prescribed to help absorb calcium because they're going to be on those calcium supplements since they don't have enough calcium. Their diet, foods high in calcium. So low-fat dairy, dark green vegetables, soybeans, tofu, canned fish with bones included. They're also going to be on foods low in phosphorus, such as soy milk, white rice, jam, honey, lemon lime soda, cucumbers, lettuce, and peppers. And the normal life expectancy with treatment, so their prognosis, they can live a normal life. So that's hypoparathyroidism, not enough calcium. What's going to happen? You're going to be weak. You're going to have some spasms. You're going to have positive Trousseau and the Chavostic sign. You want to give calcium gluconate to help increase those calcium levels. We know that vitamin D helps absorb the calcium, so you're going to give that. They're going to be on a special high calcium, low phosphorus diet. So next, we're going to be talking about disorders of the adrenal glands. So you have what's called Cushing's. This is caused by excess corticosteroids from overstimulation by the pituitary hormone ACTH and by prolonged administration of high doses of corticosteroids. So with Cushing's, I like to remember that this is dealing with cortisol. C for Cushing, C for cortisol. So this is too much cortisol. And cortisol is that hormone that it gives you comfort. So like in times of stress, cortisol is going to get released. But as a result, they're going to have moon face, buffalo hump, weight gain, hypocalcemia, hyperglycemia. So we know cortisol raises your blood sugar. They're going to have osteoporosis, kyphosis, purple striae, pendulous abdomen. So they're going to have a lot of Cushing. That's how I remember that. They're large. They have weight gain. Their blood sugar is high. They're going to have mood disturbances, irritability, depression, some back pain. You want to observe skin for ecchymosis and petechia because the skin becomes thin and fragile. In women, they may experience the hirsutism, which is an excessive amount of hair, and they may have menstrual irregularities. The diagnostic test, again, we say this is coming from cortisol, so they're going to run your cortisol levels, and they're also going to see your ACTH. Medical management, so they can do the medical adrenalectomy, so they're going to take that part out. And if prolonged administration of prednisone has caused Cushing's, the patient will gradually reduce it or discontinue the drug, or they're going to convert to an alternate day regimen. So they won't take it every day, maybe they'll take it every other day. Your nursing interventions, you want to gently handle them to prevent skin impairment since they bruise easily. You can give them the elbow and hair protectors and pressure reducing mattress, and you want to give Miditane drug as prescribed. So with Cushing's, we want to remember it's from cortisol. It's too much. They have too much Cushing. They're going to have excessive weight gain. They're going to have high blood sugar. Their mood's going to be off. They're going to have the moon face because their cortisol levels are up. So the opposite of that, we have Addison's disease. And this is not enough amounts of your cortisol, aldosterone, and your androgens. So, because manifestations are usually not evident until 90% of the adrenal cortex is destroyed, the disease is often advanced before it's diagnosed. So with these patients, they're craving for salt. And as I said up here, the cause of this Addison's, it's not enough aldosterone. And if you remember, aldosterone is your salt retaining hormone. So if you don't have enough of that, you're going to crave salt. So they're craving for salt. The patient tolerates stress poorly and feels anxious because cortisol is your stress hormone. So if you don't have enough, you're going to not be able to tolerate the stress. You're going to be weak. You're going to have skin hyperpigmentation, and you can have what's called the Addison's crisis, which is a sudden sharp decrease in your adrenal cortical hormone. So when your hormones take a dive, it's called this Addison crisis. So they're going to run diagnostics on their sodium levels because, again, they're craving salt, your ACTH, and your fasting plasma cortisol levels. So medical management, they're going to give hydrocortisone, fludrocortisone, and their diet's going to be high in sodium and low in potassium. So your nursing interventions, you want to monitor for Addison crisis, which is a severe drop in blood pressure. They're going to have nausea, vomiting, a high temperature, and that can lead to vasomotor collapse and even death. So the patient should carry an emergency kit at all times with 100 milligrams of IM hydrocortisone. So again, this is your Addison's disease. This is your adrenal hypofunction. So it's not enough cortisol, not enough aldosterone. They're wanting this salt. Their skin is going to have hyperpigmentation. So you're going to see like dark areas on their legs. So they're going to give cortisone since they don't have enough. So you want to monitor for the Addisonian crisis, which is going to be the severe drop in blood pressure. Next, we have what's called Pheochromocytoma. So this is a rare tumor of the adrenal medulla that causes excessive secretion of catecholamines, which are your epinephrine and norepinephrine. And the excessive catecholamines result in severe hypertension. So these patients are going to have really high blood pressure. So they're going to have headaches, diaphoresis, tachycardia, feelings of extreme fright. They can go into a hypertensive crisis where their blood pressure is 300 over 175. So really high levels of high blood pressure. That may result in shock, kidney damage, and retinopathy. So again, they're going to have a severe headache, palpitations, some anxiety, trouble sleeping, tremors, diaphoresis, dilated pupils, glycosuria. So they're going to have some glucose in the urine, and they're going to be hyperglycemic, so high blood sugar. So for the diagnostic test, they're going to run the urinary test. They're going to check for catecholamine metabolites. They may do the 24-hour urine collection. Medical management is surgical removal of the tumor via laparoscopic adrenalectomy. Pre-op, they can give some calcium channel blockers, beta blockers, because they got to get that blood pressure down. And they are going to give this drug, medirosin, if the tumor is inoperable. So for the nurse, you want to monitor their BP. They need to avoid excess stress, monitor their INO. Large amounts of hydrocortisone will be given. And diet free of stimulants such as coffee, tea, soft drinks, and anything containing caffeine. So that is phenochromocytoma. Again, it's a tumor, rare benign tumor of the adrenal medulla, which causes too much epinephrine. So they're going to be really, really high all the time. They're going to have this hypertension up to 300 over 175. That's going to give them a severe headache. So you want to monitor for that. So that concludes the endocrine system disorders. Go back and remember, like I said, when you're studying, make sure you study one disorder at a time. Learn the first one, learn the hyperfunction. Learn when it's too much. And you know, okay, so the hypofunction is going to be the opposite. So one of them is too much and one of them is not enough. So that completes our endocrine system disorders.